My guest today is Dr. Prati Sharma. She's an American double board certified OB-GYN and reproductive endocrinologist and infertility specialist. To make that a little simpler, we usually just say REI, so that'll be helpful as this episode unfolds. She is practicing currently at CReATe Fertility Centre, and that's in Toronto, Canada. She's also an assistant professor in the Department of Obstetrics and Gynecology at the University of Toronto, and is an active faculty member at Sunnybrook Health Science Center and Women's College Hospital. She has an expertise in PCOS, endometriosis, and fertility preservation, and she's made a huge impact on thousands of people's lives over the past decade. And she serves the wider community as an advocate and patient educator, which is a lot of what we're going to do today. Also, she's the medical advisor for a very cool company called Bird&Be, and that's B with one E, not two, like you might imagine. It's a company that supports families through their fertility journey by offering personalized supplements and at-home testing options. So today we're going to talk about what a typical fertility journey looks like. And Dr. Sharma is going to talk us through the basic steps of how and when and why, so that if you find yourself on this path, you're not going to have to walk it alone, wondering what the next steps are or when you should take them. And, for those of you who've been listening for a long time, a while back, I did an episode that I called like a primer on mental health. And I did that because we talk about mental health so often, and we often just kind of dive right into a deep subject. And I know that sometimes I might lose some people because we've just dived right in. But I wanted that episode to be there for those of you who go, okay, wait, I need to pause and go listen to this. And I feel like this episode is way overdue. And there are older episodes where we dove right into really deep conversations about fertility. And now people will have the opportunity to say, okay, let me go back to the basics and understand what this care looks like and some terminology, things like that. So, Dr. Sharma, thank you so much for taking the time to talk to me today.
Well, thank you for that amazing introduction, and thank you for having me as a guest on your podcast. I'm very excited.
Awesome. Well, let's start with you just telling us about yourself and how you got here.
Yeah, so I've always had a strong interest in women's health, and I think women helping women is really, it can't get better than that. And so from the time I was in undergrad and med school, my research interests focused on the field of OB-GYN. And truth be told, initially it was more on pregnancy. I was fascinated by pregnancy and how the progression of pregnancy went from early on, all of fetal development, and in the end you have this beautiful human being. And so that really fascinated me. And so a lot of the research I did, when I was a medical student, focused on pregnancy and pregnancy-related complications. But I realized that as much as I loved the concept of delivering babies and taking care of pregnant women, I didn't necessarily want to stay up all night in the hospital every day. And so then I started looking into the other aspects of OB-GYN and women's health. And the reason why reproductive medicine, or REI, as you so aptly put it, made sense to me was, you really build a relationship with fertility patients, because the idea of becoming a mother, whether it's now or later, is such a innate and something that we expect to happen so naturally as women. And so when it doesn't happen, it becomes a big struggle. And I know I'm talking about women. There are, other people. There's many LGBTQ patients, men, same-sex men who want to get pregnant. So yes, I take care of all of those people. But when you ask what drove me to this, in the beginning, it was exploring the concept of women helping women achieve their family building goals. And the nice thing and the interesting thing about reproductive medicine is it's a combination of medicine, surgery, cutting edge research, advanced and new technologies. And so that really drove me into this field. And so my research went into that during my fellowship. And then, yes, I did train in New York. So we have that similarity. I had some fantastic mentors at the medical school I was at, UMD&J, followed by Cornell and Columbia. And then I started my practice in REI, and I just fell in love with the fact that I could build a relationship with these patients and help them achieve their family building goals in many different ways. And, as we all know, the field of reproductive medicine has advanced so far from just, doing fertility therapy, getting pregnant and having a baby. It's also about, well, I'm not ready to conceive right now, so I'm going to freeze my eggs, or I have some gynecologic condition, so I'm worried I won't be able to conceive later, so what can we do to make embryos now? So it's just such an interesting and evolving field. With new things happening all the time. There's a lot of genetic testing that's happening. And so I just really love it. And, I've been in practice for 15 years and I hope to have a long-lived career after that. And yes, my career has gone beyond just helping patients in the clinic, but, being a true patient advocate and also being a forerunner when it comes to novel femtech and interesting new technologies, whether that be home fertility testing, AI, new vitamins to sort of optimize your chances even before you hit the fertility clinic. These are all areas of interest to me because they're in a space where we can really improve outcomes.
Well, and I think REIs are really in such an interesting position because of what you just started to touch on there. When you think about the way we may interface with naturopaths or even acupuncture, like in other parts of Western medicine, we don't necessarily appreciate or interface in an interdisciplinary sort of way with these other professions that are often seen as other or outside. And in really great REI clinics, you see a lot of different modalities going on where there is science to support those modalities.
Absolutely. I couldn't agree with you more. I think, it's funny. I just had a naturopath in my clinic today that was shadowing me. So quite on point. But yes, I think, gone are the days when just the doctor themselves does it all. And it really is a multidisciplinary team that is going to be taking care of patients, not just in reproductive medicine, but in every field of medicine.
And how beautiful is that? Because we know that people who are struggling with their fertility often have a long journey, and at least they can land in a place where resources are coming to them and they aren't trying so hard to piecemeal it all out and figure out, well, how do I know if this is, voodoo or not, right? Like they're getting the support of a whole team who's saying, this is where we have science to support these things, and this is why we use these supplements, and where we might call on acupuncture or X, Y, or Z, all those different pieces.
You got it.
Okay, so let's start at the beginning. Let's assume, almost like a composite patient of some sort, let's assume someone has recently gotten married and they want to start their family straight away and they're just like ready to go. Does that person come straight to an REI so that they can figure out if they're well? What is the path for that normal person who we don't know otherwise anything about yet?
Yeah, great question. And I think that's a question that's really, the answer has changed over the years. And the reason I say that is, if you go to the textbook diagnosis of infertility or when you should see a fertility doctor, what students and fellows are taught is, well, primary infertility, which is the patient you're probably describing, is someone who's never been pregnant before, and you kind of have to try for 12 months before you go see a fertility doctor. And we have a caveat with that if you're older, if you're over 35, you only need to try for 6 months. But as I said, gone are those days, because our whole philosophy is early intervention, early testing, and early treatment to identify any abnormalities and kind of attack those head on so that it doesn't become a problem later. So let's say this is a hetero couple that recently got married, and the woman does not have any gynecologic concerns, no irregular periods, no pain with her periods, no medical conditions that she or any of her family members have. Same thing with her partner. In theory, yes, if she's under 35, she could just try at home for 12 months and then come in. But there is nothing stopping her from optimizing her at-home fertility care. And that's where things like Bird&Be vitamins, supplements if you're around that 35-year-old mark, supplements for both the male and female, even if absolutely nothing's wrong, just to optimize egg and sperm health in that 3 months preceding conception. And that's where we have our Bird&Be female and male power packs that are excellent. Maybe she has a little bit of irregular periods and her family doctor told her at some point she might be a little bit PCOS. She could take the PCOS supplement and optimize, right? So there's nothing stopping a patient from doing everything she can at home, having an ideal body weight, starting prenatal vitamins. But let's say she does want to come in and just get checked out because she's interested in having 3 or 4 kids. Absolutely. Any family doctor or OB-GYN, or you can even self-refer yourself to a fertility clinic pretty much anywhere in North America. And it's very legitimate to get checked out to make sure there's no issues. But I also put the caveat in that these days patients are very educated. And so there's so much information online, some of it good, some of it bad, but patients really are educated. And so they know that irregular cycles or having some sort of hereditary disorder in their family, or the male having, a father or 2 uncles that had difficulty conceiving, that this could be a red flag indicating that they might have issues. Or they have a family history of a genetic disease that they're worried could propagate into their children. And they're like, do I need IVF and genetic testing of embryos? So couples, single people are very savvy and they come to the fertility clinic sooner. And I could not be happier as a fertility doctor. So long-winded answer to your question of, can this couple come in? Absolutely, they can come in. If there's no red flags, could they try for 6 months to a year first and then come in? Absolutely. But I think we're being a lot more proactive than reactive these days when it comes to reproductive medicine and early intervention.
Yeah, so what I'm really hearing is that individual choice and knowledge base plays a huge role in this decision.
Yes.
I would also just add to that from the midwife perspective that I want to make sure that people come in more often for a very basic preconception care visit, which of course we don't get reimbursed for. There's terrible coding for these kinds of things, so we just kind of mush it into our annual exams, and that kind of stinks because we can't be as detail oriented as we'd like to be, but we can always have a follow-up visit if we need to. I want to make sure people understand some of the basics of fertility, because while at the same time I love that you pointed out that people know a lot these days, there is that caveat, as you said, of misinformation that's out there, but there are also people who still don't know certain things. For instance, what days of your cycle you can actually get pregnant. Very basic things sometimes can solve a problem before you ever have it. So I just want to get ahead of all of this stuff and deliver that education in a really fun, interactive way. I love when partners come along and learn too. So yeah, that's great. You answered like 3 of my questions just in that one. So that was amazing. Are you pregnant or a new parent looking to ensure a better postpartum experience? Or are you a birth worker looking to improve your postpartum care skills? Check out Thriving After Birth, an online self-paced course by me, midwife and educator Tanya Tringali. It's 10.5 hours of video content featuring experts in lactation, mental health, pelvic floor health, pediatric sleep issues. You also get worksheets and a workbook, as well as options to have a one-on-one session with me. Sign up at motherwitmaternity.com/thriving and let's improve postpartum care together. Now let's assume we've had 6 months to a year and they were a properly educated couple and they are not pregnant. And they come to you for an initial consultation. I kind of would love to give listeners a sense of what to expect at that visit, because I'm sure there's a lot of nerves coming into that. And it's not a visit I've ever had myself as a woman who had one baby at a young age and never had any more. It's not something I have personal experience with. I think I know what gets covered, but I think it would be better coming from you.
Yeah, no, and I mean, you hit the nail on the head. There is a lot of anxiety, and mostly because it's like, well, why isn't this happening naturally? And so a lot of my job in that first initial consultation is getting to know the patients, allaying their fears, myth busting, saying, it's not your fault. And then, kind of like we learned in medical school, a good history takes you a long way. So, I spend that hour getting to know patients, their medical history, with particular focus on their OB-GYN history, looking at, for the female, regularity of menstrual cycles, any pain symptoms with menstruation or otherwise that could be signs of endometriosis. As you touched upon, are they having regular intercourse in their fertile window? Because you're right, some people might not know that you should have intercourse day 10 through 14 every other day. So really understanding where they've been at home and how they've been doing this. Have they been trying every month, or has it been like, kind of we try, kind of we don't? A good male history, surgical history, any medications or toxins that they would be exposed to, obviously their age, any family history of significant disorders that could impact their own fertility or genetic predisposition, and all the routine preconception counseling about genetic screening based on risk factors, their ethnicity, or potentially just offering carrier screening to both partners to make sure that they're not any carriers for recessive genes that both could have and pass along to children. So that initial consult is getting to know their own individual personal history, and what they've done to date. Some patients come in and they're like, oh, I've been using ovulation kits, like the one from Bird&Be for a year and it hasn't worked. Some patients say, well, we haven't really been trying, but we haven't really been using contraception. And sometimes things come up on the initial consultation that direct my diagnostic test. So then I kind of formulate the diagnostic test that I'm going to do. I think for simplicity, we'll talk about the female workup and the male workup. And obviously, if there's two females, then both of them potentially would undergo that workup. If it's two males, both of them would undergo that workup. But for simplicity's sakes, just focusing first on the female, they undergo ovarian reserve testing, which is assessment of their egg number and egg quality, and just reproduction 101. As a woman gets older, and particularly as she reaches 37 and even more when she reaches 40 plus, there's a depletion of the egg pool. You're born with a certain number of eggs, and over time, until the age of menopause, which the average age is 51, it's like use them or lose them. You lose eggs, and contrary to popular belief, it's not the one egg that you ovulate every month. There's a whole cohort of eggs that grow and are used up every month. So it's just a whole bunch. That's just how we were made. And so at any given point, you can do an assessment for egg reserve by doing an ultrasound and something called the antral follicle count. So it's the follicle count in the ovaries. Typically, we like to see anywhere between 10 and 20, ideally at any age, but I'm used to seeing under 10 follicles per ovary in the over 40-year-old population, and certainly closer to 10 to 15 follicles per ovary in the under 35-year-old population. We correlate that with some hormonal testing, which would be the anti-Müllerian hormone, or AMH level. It's a blood test that assesses the egg reserve, and day 2 or 3 menstrual cycle blood work, which tests reproductive hormones, the FSH, the LH, and the estradiol levels. And so that's ovarian reserve. We also do an anatomic check, which is typically a hysterosalpingogram to assess for fallopian tube patency. So anatomic lesson is you have 2 ovaries most of the time, unless you had surgery or were born with 1 ovary. And the fallopian tubes, 2 of them connect your ovaries to the uterus. And so we want to make sure those fallopian tubes are open and can allow the egg to travel into the middle part of the fallopian tube, so that when the sperm meets up with the egg, fertilization can occur and the embryo can travel into the uterus. So that's the anatomic study. Sometimes we'll also do something called a sonohystogram, which is a saline water test of the uterus to make sure the inside of the uterus doesn't have any lesions, polyps, fibroids, scar tissue, evaluation of a prior C-section scar. And then we also do basic reproductive hormone testing, including thyroid levels, prolactin levels. Most people are offered a genetic carrier screen to make sure they don't have any sort of background recessive mutations that can pass along to their child. And that's sort of basic primary or secondary infertility testing. There's all kinds of other tests if you've done IVF before and failed and are a more complicated patient. For men, they also undergo blood testing. And sorry, I should mention that for females, they'll have sexually transmitted disease testing to make sure that they're not going to pass along something potentially to a child, cervical cultures for gonorrhea and chlamydia, and if they need a pap test, they would have that too. For a male, also, we do STD testing. One more thing for a female, we'll do preconception blood work to make sure she's immune to any sort of viruses that can affect a baby, viruses or bacteria like German measles, parvovirus, varicella. So all the preconception testing, blood type, and antibody screen. And so now for the male, sexually transmitted disease testing, blood type to make sure that they're compatible in terms of Rh factor, and a semen analysis. The semen analysis is done on ejaculated sperm. It looks at the volume, the count, the motility, the shape of the sperm, the pH of the sperm, and a bacterial culture to make sure there's no bacterial infection. Some people would advocate for doing further sperm testing in specific situations. So that's really the consult and the basic diagnostic testing. Once that all comes back, I meet my patient in follow-up and we review those tests and what the results are, and that's where we formulate a plan for treatment.
So I was taught in midwifery school, and I have continued always through my career to do this, and I'm wondering if you have a position on this. I won't even offer or refer or begin any of the invasive, so to speak, tests. So when I say invasive, just so our listeners are following, we're talking about that saline infusion sonogram. We're talking about all of that kind of stuff where it can be, even though it's not a major surgery or anything like that, it's not necessarily comfortable. So I don't usually go to that level unless, assuming a heterosexual couple, the partner has had a semen analysis, because I don't think it's right or fair, and this is what I was taught, and I really took this home, to put the female partner through all of that if we're going to find out that there's an issue with the male, because I have had a number of couples who the male just doesn't show up at the appointments, doesn't want to come, or maybe he doesn't have health insurance. There's a lot of reasons. I don't mean to just blame him for not wanting to, but I do see that a lot. So I wonder if you feel strongly about that, or if you if you move forward with the evaluation of the female, regardless of what's going on with the male partner.
I mean, each situation is unique, right? I mean, I think any fertility doctor and clinic will encourage both partners to be present from the beginning, because we know that male factor infertility is 25 to 30% of infertility, right? So I fully agree with you that you don't have 30% of the picture if you're not testing the male. But I also will say I have been in those situations where the female comes in and says, look, my partner is just anti-doctor. He's not interested in coming in. He didn't even want to come to a fertility clinic. He wanted to continue trying naturally for some time. And so I think in that scenario, it's worthwhile getting the full female workup and then saying, look, you have blocked tubes and you're 40 with low egg reserve. I think you should go back and talk to your partner. And I'm always willing to talk to them if you bring them along before we do testing and explain the situation and say, look, we're going to have to consider potentially more aggressive assisted reproductive technology given the female results, and obviously to do that we need sperm testing. But yes, I think we definitely encourage both partners to participate because, you know, I think as women we tend to blame ourselves and say it's my fault and it's not him.
Exactly it.
And the problem is that men don't have any obvious symptoms when there's a male factor infertility for the most part.
Right.
And so they could have low sperm counts and not have any stigmata, whereas women have irregular periods, pain, all of that stuff. So it's just more presentable. So yeah, I mean, I think we try to educate our patients when these scenarios come up and say, look, there's a possibility. It's very important that we test your partner, all of that. And that's where good counseling and, an open discussion is very important.
Yeah, you really hit it on the head there, because that is, I think, why my motivation is so strong, is I feel so bad for particularly women who are struggling with fertility issues. There's already such a burden. There's already such a load. And if we could just remove a little bit of it, but also create a little more of a bond in that relationship that we're in this together. Like the least I can do is give a semen analysis.
Well, I
right?
usually
Like
say infertility is a couple's diagnosis, not a singles diagnosis. It takes two to tango. But, I would arguably say, I also think things are changing. And yes, I've been in the situation where the woman says it's all my fault. I know it's me. But I think there's also been a remarkable focus on male health, male reproductive health, the fact that male infertility has ways to improve sperm counts and sperm quality, lifestyle modifications, vitamins. We had a study that was published by Bird&Be on the sperm vitamins that showed a dramatic improvement in sperm parameters by taking the vitamins. And I think men are also more interested. I have a lot of men that come to me who have abnormal sperm parameters, and they're like, what can I do to help? So I think the narrative is changing, and men do want to participate, which is a good thing. But absolutely, I agree with you that there's this kind of stigma and feeling that it's my fault for women. And so the solution is just to have both partners involved from the get-go, ideally.
Cool. I agree. Can you tell us a little bit more about what one's ongoing follow-up looks like? So after that first visit, clearly they're going to come back and you're going to have to spend a lot of time reviewing the results of all the things that you just discussed. But beyond that, what do those visits look like, and how does the care unfold from there?
Yeah. So, the trajectory is going to be different for everybody. I would say the time from that initial consult to that follow-up appointment, meaning you see the doctor, you don't have any sort of time delay. You're like, I'm going to get the testing done right away. And having a follow-up can be as short as 3 to 4 weeks to get everything done, because some of it is based on your menstrual cycle. So usually within 4 weeks, patients are given a follow-up appointment. And then it's a discussion, because it really depends on patient specifics and patient desire and what they want to do. But there's sort of, to me, 3 buckets of treatment. One is medicated IUI, where you take medication in the form of oral pills or injectable medication to help ovulate 1 or more eggs. And you take the sperm, wash it to improve its parameters, and put it into the uterus. It's called IUI. And really the effective goal there is to bring more eggs and sperm together to increase the chances of conception. And this is kind of what I call starting entry-level treatment in the fertility clinic. It's not as expensive. It gets you familiar with everything. It increases the odds. It's a good treatment for young patients with mild male factor or ovulatory dysfunction. And so lots of patients start with this. The one caveat is the higher multiple risk, which patients have to understand. And so that's one bucket of treatment. This next one is IVF, and there's certain indications for that: advanced reproductive age, low egg reserve, blocked tubes, severe male factor, need to do genetic testing because some genetic disorders in your family, or just for embryo banking because you want multiple kids, or maybe you're egg freezing. So, that discussion all happens at follow-up, and if a patient's starting either IUI or IVF, unless there's something that has to be corrected, like they have to get a cyst removed, or sperm has to be extracted from the testicle, or they have a medical condition that needs to be optimized, most patients can start reasonably soon after the follow-up and start with either IUI or IVF, barring finances and all of that and travel and whatnot. And the third treatment is any sort of third-party reproduction, which is an egg donor, a sperm donor, or a gestational surrogate. Those things are a little bit different because you need to find the egg donor, the surrogate, or the sperm donor. There's some counseling that takes place. There's some other testing that you need to do. You need to match with a egg donor or a surrogate. So those things can be a little bit more prolonged in terms of treatment. But if we're talking about medicated IUI or IVF, hopefully you can get the patient into treatment soon, because again, patients are other than the egg freezing population and the embryo freezing population that's coming to me because they're not ready to conceive and they want to conceive later, so they're just going to freeze eggs now for later use. Most fertility patients, they wanted to get pregnant 6 months ago. So coming to me for the initial consult, they want to get in as soon as possible into treatment. And I think our goal is to improve efficiencies and make sure patients are very well educated so that they can follow the right treatment path as soon as possible and hopefully achieve success.
Hey everyone, it's me, Tanya, your host here at the Motherwit podcast. I sometimes invite my clients on the show to talk about their birth stories and postpartum experiences, but I want to tell you a little bit more about what those clients and I actually do together. I started MotherWit to help people in the perinatal period achieve their health and wellness goals. That means whether you're hoping to conceive and struggling with high blood pressure or high blood sugar, or you're having trouble managing anxiety or depression in the postpartum period, or maybe you just need support and advocacy between prenatal or postpartum visits, I can help. Get a discount on your first consultation with me at motherwitmaternity.com using the code FIRSTCONSULT 10% off. That's 10% symbol, all one word. I'm looking forward to working with you and maybe having you on the show too.
We hope you're enjoying the MotherWit podcast. If you are, please rate us and leave a review in iTunes, Spotify, or wherever you're listening to your podcast. Thanks so much. Now, back to the show.
Regardless of the pathway, I don't necessarily want to make you get into too much specifics, but we started this conversation talking about naturopaths and acupuncture and all these other things. How and when do you weave those into patients' care?
Yeah. So, I was just saying this today. I think just discussing the reproductive medicine and the options is a lot. So as fertility doctors, that's our focus, but we also focus on optimizing lifestyle and whatnot. And I think this is part of the reason I have gotten involved with companies like Bird&Be, because we know we can push the system with medication, we can do IVF, we can get sperm and eggs together with IUI, but if the host or the eggs or the sperm are not very viable, the success rate is lower. So that focus on proactive and preventative care is huge. And so I try to mention lifestyle changes and optimizing vitamins and supplements. I try to mention that in the first initial consult, because sometimes patients will have the initial consult, they need to think about things after the follow-up, they need to get their finances together, they have a break because they have work or traveling. So sometimes it's 3 months before they get into treatment, and that 3 months could be utilized to optimize their natural fertility at home too. And while you're doing fertility care, like I would love if every patient of mine got pregnant with the first cycle of IUI or the first cycle of IVF, but we know that the system is not perfect and treatment doesn't yield 100% success in one cycle. So most patients are doing multiple cycles, whether that be a few rounds of IUI and then moving to IVF, or needing 1 or 2 rounds of IVF to create enough viable embryos for their family. So throughout that treatment, you want to optimize yourself. And so even in the follow-up, I talk about ways through vitamins, supplements, diet, exercise, weight loss, and mental health too, that you can be at your best. And that might involve seeing a naturopath or an acupuncturist, specifically to target those areas, or it just might be a discussion with me saying, look, these are the vitamins I recommend. Why don't you try those?
Can you talk a little bit about managing expectations as it pertains to average success rates? How do you talk to people about that? Because managing expectations is such a huge part of the job, I would imagine.
Yes, it is. And I won't lie to you that that's something that I've really honed and developed over 15 years. It's not something that comes super easy on day one. And I think the reason is that it's not set in stone. Everyone's success rate is going to be different. And to have patients understand that this is a marathon, not a sprint, is tricky, because everybody, both doctor and patient, wants to get pregnant on the first try and be a success story, right? And sometimes it's just chance. Like, we know the IUI success rate per month, no matter what you do, is probably about 20%. And the IVF success rate, even with making perfectly genetically normal embryos, the embryo transfer success rate is 60%. So that's a whole 40% or 80% that are not going to conceive in one cycle. And so I try as much as possible to give patients the data, whether that be in the initial consult or typically the follow-up, and say, this is what the data shows. And based on this data, I think this is the treatment that's going to serve you the best now. But we have to take into consideration your individual situation, not just your medical situation where, it might be the right choice to do IVF, but your financial situation. You might say, I need 4 to 6 months to gather all the funds for IVF. So could we try IUI for a few months? And as long as we're under the understanding that, yes, it's a lower success rate, but it could happen, have realistic expectations. But I'm also the first to say, like, look, you have a really good chance. I think this is going to work in your favor. It might not work right away the first try, but I think you have a really good chance and the prognosis is good, because it's a really stressful situation, and sometimes it's a shorter journey, sometimes it's a longer journey, and anything you can do to encourage patients, without obviously giving them misinformation is a plus and a bonus, because they feel good.
It's a marathon. You're preparing them for a marathon, yet the message society is giving all women, let alone women who are struggling with fertility, is that the clock is ticking.
Yeah.
Right? So it's like these two things that are,
Totally
just completely oppositional to each other. So you've got to get someone in this mindset to be prepared for the long haul, while every other message around is saying, I've got to do this yesterday.
Yeah, no, and I fully appreciate that. And I think that's where the counseling comes into play, because it's stressful and hard for patients to hear, you're 37, we have to get this going quickly. Mm-hmm. And so, as my job, it's to, it's to say, if you ask me as your medical doctor, I think this is the best treatment for you. Are there other ways we can do this? Absolutely. So let's look at all those different paths and see what path makes the most sense. But to be transparent and say, look, at 37, even if IVF's not right for you right now, I would say that within 4 to 6 months at most, you should do IVF, because I worry about time passing. So it's all about how you frame the conversation. And it's a tricky one. But this again goes back to the fact that it's important to build a relationship with the patient and build trust. Because we all know that the dropout rate from fertility treatment is quite high, because in no other field of medicine is it that every month you're waiting that 2-week wait, finding out if it went well or it didn't, and then it's negative and you have to start again. So you can imagine from the disappointment, there is a significant dropout rate from fertility treatment. And the patients who come back, it's not necessarily whether they succeed or don't. It's that they had a good experience and they felt like their doctor was on their side, and they had a care team. So not just the doctor, but all the allied health professionals, the clinic staff, the nursing team, that, they had those people on their side, and there was a plan in place for next steps.
Building that relationship and building that trust was exactly where I wanted to go next, because that has to be the key. And when I talk to women, which I do every day, I have heard many positive stories about their experience of their fertility journey and the providers they worked with. But I've also heard some stories that are just kind of a sad embarrassment of what our system has come to. So whether it's, misinformation is probably not the right word, but conflicting advice, I'll say, from perhaps 2 different providers within the same practice, or it's just like an inability to deal with the timing of the situation properly. So as you started to discuss, or you did when you were going through the list of tests, I'm not sure if you said this now, some of these tests can be very time specific, right? Getting your progesterone level, things like that. You've got people who are trying to figure out what day this is falling on and trying to get into the clinic, and then they miss that opportunity. And that's just devastating for people. So building this relationship in an environment that works for everybody is key. And it's so clear to me that some clinics, they have it down, and some they don't. So what would be your advice to people who aren't lucky enough to work with you, who are navigating this, journey where maybe they have somewhere between 1 and 3 options? That seems to be about what I see when I'm looking at somebody in a given geographical area. What is it that they can either look for or do to advocate for themselves in these situations to get better care?
So, I think you have to find a clinic and a provider that you gel with. And so I don't think it's unreasonable to speak with a few different doctors in a few different clinics. So for that patient who has 1 to 3 options, doing a consultation, an initial consultation with a couple places is reasonable. That being said, I think most patients will get a referral from their family doctor or their OB-GYN. And so I feel that you can put trust in those people because they've worked with the fertility doctor. And if they say, okay, I've had patients who have been really happy with this clinic and this doctor, then you have some trust placed in that. And when you have your initial consult, you do get a vibe for your doctor. And if they are making sense in terms of their diagnostics and their treatment plan and their openness to, consider various treatments. So most patients can decide just from the initial consultation. I mean, I think it's reasonable to look at doctors' reviews. Like, everything's online, and patients will go online and say the good, bad, and the ugly. And listen, no doctor's perfect. I'm sure every doctor has a couple of bad reviews. And same with the clinic. I'm sure the clinics all have good and bad reviews, but reading the reviews will give you some idea of the challenges people might have faced, but an overall picture of the clinic. Ask friends. Like, I think this topic of infertility is not so taboo anymore, and people are talking. And so I get a lot of patients that say, oh, I came to you because my friend came to you, or I came to your clinic because my friend came to your clinic. And so those are always positive interactions. And then once you're in the clinic, make sure you know who your care team is, not just your doctor, but how to reach nurses in case there's a problem. If you forgot to take a medication, if you think you injected something wrong, if you have symptoms, like, make sure you can reach and access your care team, because that's going to be important. So ask questions like, whether it's in the initial consultation or the follow-up, what will I do if I have any problems? If I'm doing IVF, am I going to be sedated enough that I don't feel any pain? What are the different treatment options? How much is it going to cost? Do you take insurance? So all of these questions will empower patients to have control of their journey and feel comfortable. And so there's no question that's unreasonable. And I think it's important to speak up and ask all of these things, because that's the only way you'll know if you are comfortable. Make sure you have access to your doctor. Now, obviously, having access to your doctor every day and every second of the day is not necessarily possible, but I hear a lot of patients who say, well, I went through a treatment cycle and it failed, and I couldn't get an appointment with my doctor to discuss next steps for a couple months. Now, there's a lot of different ways to handle this. You could have a cycle plan for a few months so that it's not like you have to wait a couple months. But what if you really want to talk to the doctor? Maybe you've done 2 IUIs, they've failed, and you're like, should I do IVF or should I keep going with IUI? I want to talk to the doctor. There should be a reasonable time period from which you can get some sort of follow-up from your doctor. And I find that patients are very frustrated when it's like 3 months before they can see their doctor again.
What do you consider reasonable?
I mean, I would say when you're, at a crossroads about treatment, or you're wondering what to do with your next cycle, like, I think to have some sort of answer within a week is very reasonable. The nice thing about most fertility clinics is it's kind of like a rolling admission. Like, you can always go back in for your next cycle and start something. And so we tell our patients, when in doubt, just come in with your cycle start. And even if you haven't had a follow-up with the doctor, we can cycle plan. Now, that's a little bit more complicated in places where you need prior authorization and medication and whatnot. Mm-hmm. But I would say don't skip more than 1 cycle, because 2 or more cycles is time lost.
Yeah, that's fair. What haven't I asked you that you think the average person out there who is hungry for this information needs to know?
I mean, I think cost is a big concern as well. And obviously cost is going to vary based on your geographic location. But I always tell patients, like, and we can talk a little bit about the average cost, but it's also important as part of this whole process. So I'm a fertility doctor. I focus on the medicine, the medical care, and the treatments. I have allied health professionals like naturopaths, who support us and support patients with optimizing natural fertility, dealing with egg and sperm quality with supplements. But we cannot forget the financial piece and the mental health piece. So in terms of the finance piece, it's always good to meet with your financial planner, get an idea of what extra funds you have to pay for fertility treatment that might not be covered in certain jurisdictions. Do you have some sort of pharma plan, drug plan, insurance health plan that covers fertility drugs? It's always good to know that beforehand. And then kind of understanding the cost of treatment when you have that follow-up appointment. IVF without any coverage is anywhere between, $10, $12, $15, $20,000 per cycle. So that's a large amount. When you get into third-party reproduction with egg donation surrogacy, it's in the 20, 30, 40, 50,000. So this is expensive stuff. Yes, coverage is increasing. Third-party coverage is increasing. Government-mandated coverage is increasing, but we're not there yet where it's fully covered. Fertility drugs are also expensive. And so knowing if you have a drug plan that'll cover your drugs is also important. IUI is usually cheaper in the range of $1,000-ish, depending on what kind of medication you're using. An IUI cost, so it's less. And then, know who your support system is: friends, family, patient groups, online support. Most fertility clinics have fertility counselors. Like, these are available to you. Please don't feel afraid to ask, because you're not expected to do this all on your own and bottle it all up. And there are ways to ease the journey. And I'm just so glad seeing the conversation be so open. There's lots of fertility coaches out there that help you through your journey. So, use those things, because that's going to be what's going to get you through and make it, compatible with your life, right? And so the expectation is not that you drop everything and just do fertility treatment. It's supposed to integrate with your life and hopefully not be a harrowing journey. It's supposed to be the patient experience through the journey is as important as the outcome. So hopefully that was helpful.
Oh, it was very helpful. And while you were talking, I realized what the question is that I nearly forgot to ask you, that I think is so important and would have been so sad had I left it here.
Sure.
The question is, tell us what happens once someone calls you and tells you that they have a positive pregnancy test.
You mean after we do our celebration dance and little jig? I mean, all those beautiful things. So we're always very happy, obviously, but there's a huge population of patients that have miscarriages. And so it's always sitting on eggshells and fingers crossed, even with the positive pregnancy test. But the way things go in most fertility clinics is that you monitor those levels for about a week and a half or so to make sure the levels are going up appropriately and not down. And it's not a non-viable pregnancy or a pregnancy in the tubes, an ectopic pregnancy. So assuming you get past that hurdle, then it's the 6-week viability scan to see the pregnancy in the uterus with a heartbeat, hopefully only one at a time. And then it varies from fertility clinic and provider to provider. In our clinic, we're a little bit unusual. We follow our patients until 12 weeks of pregnancy. So we also do their prenatal screening, the NIPT and the NT test, to make sure that the embryo is chromosomally abnormal and the fetus is normal. But I would say most clinics discharge their patients after viability is confirmed at 6 to 8 weeks, and they go off to their provider, whether that be a midwife or a OB-GYN. And that's always a nice day, the graduation day.
Oh, totally. I love getting them. It's always such a joy to know that they've kind of graduated through that stage, and we can kind of breathe and slow things down a bit, and they're so excited usually. So that's great. Yeah, I wanted to make sure we touched on kind of that transition, because I don't think people realize sometimes that they don't stay with you.
Yes.
They get attached to you, and they don't realize that they don't stay with you.
I know. My favorite line is, "I don't think you want me delivering your baby. It's been 20 years since I've delivered a baby."
I guess that's a good way to create some separation, huh?
Yeah.
And from there, I think the next challenge for people is not treating themselves like they need this label of high risk just because they had difficulty becoming pregnant. That's not to say that there aren't things that we know in the literature we do see some increases of certain things in IVF pregnancies, all of this stuff, but we don't label you in advance of those things occurring. And you are normal until something happens where it's not normal. And that's what I find my work is once they come to me is, well, first of all, if they're choosing a midwife, it's because they want normal and they want to be treated normal for sure. It's already better, but I can still feel that we need some time to let some of that anxiety go and really dive into the feeling of I'm normal and I can do the rest of this just like everybody else, right?
I actually see that a lot too. When patients are there for their 6-week scan, they're like, so I'm going to be referred to a high risk doctor, right? Yes. And I'm like, no, you don't need that. You're low risk. Yeah. So it is. And looking at it from the patient perspective, you're right, because all through their fertility journey, they were treating something that wasn't happening naturally. And so I'm sure when you see the patients, it is really nice to sort of slow it down and say, let's take care of this like a normal pregnancy, obviously with close eyes.
Well, and it's a little like when you said, yes, we get the positive pregnancy test and that's exciting for a minute, but then it's kind of anxiety producing for a while as well. I think it's just so hard to transition out of that into the next phase. I see this often especially in my virtual practice where I work with clients very carefully and very closely on a lot of lifestyle management and all of that kind of jazz, things that people aren't getting in a robust way in their in-person services. There's a lot of hand-holding about one fear that morphs into the next, that morphs into the next, that morphs into the next. And I think that's really where the journey is and why people need a lot of support who have undergone any amount of struggle with their fertility journey, and whatever it was that finally got them pregnant. It's harder. I believe it's harder for people who have had this difficulty at first to just experience the pure joy that can be there for some. Not that everybody loves pregnancy, they don't, but that could be there for them if they were able to let some of that anxiety go.
Yes.
Anyway, anything else that you think I'm remiss in? Is there a note you'd like to add?
I mean, I think the only other thing I would touch upon that we didn't touch upon so much is we talked a lot about infertility, diagnostic tests for infertility, and treatments for infertility, but you don't have to see a fertility clinic only if you're infertile. And I'm a big proponent of this. Like, we know that women are pursuing their career, delaying finding, quote unquote, their right person for some time because they have goals in life. The average age that women are having their first child has become later and later. And so unfortunately, the biological clock does not stop. And so if you are someone that's not ready to be pregnant now, but want to be a mom later, we're in this day and age where egg and embryo freezing, because it could be also a couple who's not ready. It doesn't have to be a single person who's not ready to conceive now, but you're young enough that hopefully you have healthy enough eggs, or maybe you have a family history of early menopause. Come see a fertility doctor without being infertile to do an evaluation and consider egg or embryo freezing, because fertility preservation or elective fertility preservation is not experimental. It is considered a very reasonable treatment for preventing future fertility issues, and the success rate is very high. And so if you're not going to have kids for a while for any reason, seek out fertility care sooner. And we know that the data shows if you freeze eggs earlier, like ideally under 35 and particularly under 32, your successful outcomes are going to be much higher.
What is the ballpark cost of freezing eggs over time?
It varies. I would say on average, it's probably about anywhere between $10,000 and $20,000, depending on where you are. There are some insurances that cover egg freezing, and more are starting to cover them. Third-party payers like CReATe, I'm on their board, and Progeny, and even employers are starting to cover egg freezing. Google, Facebook, they're all offering it because they know to retain their employees and have them work hard, they want to be able to offer them family building plans. And so that's really great. I think that's real progress in the field of reproductive medicine. But obviously not everyone is covered, and so it can be expensive, but it's a really good investment for your future.
Awesome. Thank you so much for taking the time to walk us through this. I really think people are going to value having this information very concisely in about an hour. Yeah. I think that's
I feel like
really
we could do 10
people.
Podcasts on this. I was thinking already, oh my gosh, we didn't discuss what IVF really is and how the 100%. Medications go. So we'll have to do another one to answer further questions.
After this, we can do a deep dive on other subjects if you would like. I'm down. Sounds great. Thank you so much for your time.
You're welcome. You're welcome. It's my pleasure.
Thank you for listening to the MotherWhip podcast. If any of the issues we discussed today resonate with you or your experience, I'd love to hear from you. Leave me a voicemail at 917-310-0573, or better yet, email me a voice memo at tanya@motherwhipmaternity.com. I really want to hear what worked for you, what didn't work, what support you'd wished you had, how you got through the tough times, how you advocated for yourself, or especially any tips you want to share with our listeners. I want to hear all of it. And if you'd really like to work together, you can get a discount on your first consultation with me at motherwhipmaternity.com using the code FIRSTCONSULT 10% off. That's 10% symbol, all one word. Okay, that's all. It's wonderful being in community with you all. Thanks again for listening, and see you next time.
And remember, listeners, Nothing we discuss on this show should ever be considered medical advice. Please speak to your local provider about anything that comes up in this show that resonates with you and your needs and your health care.